If you were admitted to the hospital and your heart was to stop beating, would you want to have CPR, drugs, electricity, a tube placed down your throat, and put on a machine to help you breathe? This is a pretty important question that when I admit people for the first time, it takes many of them off guard, but is an important question to have with yourself and with your family about what you would want to do in a moment of crisis. I hear a lot of folks tell me that, well, let's just give it a shot, give it one try, let's see how it goes, or I'll wait and I'll ask my kids or my wife or something to do what they would want in the moment. Well, the difficulty is in the moment I have to do everything. And a resuscitation in the hospital or outside of the hospital is not a great heroic event. It's quite violent. It's breaking of ribs. It's very traumatic for family members if they're there to witness. And this type of discussion, I think, is something that needs to be thought about ahead of time. In this episode, I hope to break down kind of exactly what code status is, why it's important, and what are the questions that you should ask yourself, not just for you, but also for your family members around this decision. Within the veteran community in particular, I think that there's a certain stigma around some of these questions, especially with kind of the rabid independence that many of us have. Also, a mistrust that many folks have around the government and authority and healthcare can kind of add to this difficult conversation. And a code status can be broken down largely into kind of two umbrellas. There's a lot more nuance that I hope to get into in another episode, but broadly we would have something we call a full code, and that is I do everything for you. You will get the CPR with the chest compressions, people blowing air into your mouth. If you need to, I'll shock you. I'll give you special drugs to try and restart your heart. Give you special medications, and you will be put on a ventilator and moved into the ICU. On the opposite end of the spectrum, we have a do not resuscitate or DNR, which is will support you up until the moment your heart stops beating. But if you do go into an arrest and your heart stops, we'll focus on making you comfortable and allow a natural death. What a DNR is not a withdrawal of care. We don't stop if you came in for a pneumonia or a broken hip or something like this. We don't stop those treatments. But if your heart does stop beating, we will focus on comfort. One of the tough questions I think is everyone has to ask themselves is there's kind of this balance of quality over quantity of life. And by electing to go for a full code, I think, or a DNR, is what are we trying to preserve? What is the patient? What do you want to preserve? Is it living independently, being able to recognize your family? Is it a long recovery? Is it maybe prioritizing comfort over the number of days you might have left? And is a recovery in a resuscitation that realistic? There is a interesting calculator if you're curious about kind of what your own or your family members' likelihood is of surviving a resuscitation, called a GO-FAR score, GO-FAR, and you can look at it on different websites. The one I use a lot is MDCalc, MDCALC. I have no financial interest in any of this, but it's an interesting resource if you kind of want to see what the numbers look for you or maybe someone you care about. And the other piece to this is that even surviving a resuscitation is the chance to be discharged, to be neurologically intact. Where you have a cardiac arrest, whether it's in hospital or out of hospital, and in this case, I'm just going to kind of talk about in-hospital care, matters. But if you're out of the hospital, you have a time between where CPR might have been started and the time you went down that allows for your brain to go without oxygen for a period of time, which can be quite life-changing. And even if your heart comes back, you might not be the same person you were before that event. Interestingly, in JAMA, they looked at kind of changes in code status after somebody had already undergone a resuscitation, and about 25% of patients within 12 hours of cardiac arrest immediately reversed their course. I think that's kind of one anecdotal I think is telling of the trauma and the degree of how difficult it is, and also what the recovery looks like, especially after something like this happens. Folks who are sicker, older, if you have low blood pressure when this happened, severe organ dysfunction like very advanced kidney disease, liver disease, heart disease, if the type of arrest that you had, if you didn't have a pulse when it occurred, affects those outcomes. As a matter of fact, I had an older patient that I was taking care of my last service, where I was going back in the ICU and revisiting codes, not just code status with the family and the patient, but they had developed an unsafe heart rhythm that would have required electricity for me to help correct if it happened again. And based off our other conversations, it sounded like that would exceed what the veteran would want. And we talked about this and tailored the plan even more specifically to this particular case. And I use this example to say that just the decision that you make in the beginning or at the start of the hospitalization, when that hospitalist or APP walks in the room to ask you about your code status, isn't written in stone. It's a very dynamic situation that will change with the clinical course that you're going, that you or your family member is going through. When kind of assessing what your likelihood is of surviving a resuscitation and coming out in a meaningful way, there are some factors that increase the poor prognosis. Again, like I said, organ dysfunction like livers, hearts, lungs, and advanced disease, cancer, patients who are septic or have very low blood pressure, and also folks who are very frail, usually around advanced age. These type of underlying conditions before the arrest even happens lowers the likelihood of successful resuscitation. And I'd like to say that a full code is and having all those things done is not necessarily hope, and the DNR is not saying you're giving up. But what I think is, in terms of the full code being hope, is that is most appropriate when we know the conditions that bring you or your family or someone you care about into the hospital are reversible. There's a chance for a meaningful recovery that aligns with the patient's goals, and that the act of CPR and undergoing a resuscitation also is supportive of what the patient would want in their goals. Something like switching to or considering a do not resuscitate order is quite appropriate in folks where those things might not be true, where CPR is likely, surviving a resuscitation is not going to lead to a meaningful restoration of life, where the patient would not want to be dependent for probably a prolonged period of time on machines and lines and tubes for survival. Or, and I think this is probably the most nuanced one, is that the advanced illness or the cause for what brought you in, the person into the hospital, is irreversible, or is so advanced that intervention is unlikely to help in any meaningful way. Sometimes these decisions, I think, can also be made kind of early. And we ask everyone coming in the hospital because we need to know what to do in the event of an emergency. But it's quite easy in the moment to be, or before this happens, to be, cavalier is not the right word, but to say, this is the things I want to do. But when you have to look and make that decision, for yourself, or if you're asked to make it for a family member about what they would want, it's a very tough place to be, and it can be a very tough conversation to have. I think what recognizing or accepting what a DNR status would do, I think, is also anecdotally creates a level of, for lack of a better word, peace or acceptance around advanced illness and age and things like this. And I think that level of acceptance can be healthy and allow folks to have some level of peace with where they are in their life and with their current health conditions. And I think this can be very hard, especially with veterans who have gone through some tremendous things in their life and training and these sorts of things, where that idea of not being so strong is, or not being able to overcome everything through sheer force of will, can be very difficult. I know within the VA system, they have a life-sustaining treatment discussions and things like this, and some palliative teams and palliative medicine to come, and we'll be able to meet with families and veterans when they're admitted. But some of the things can be important, though, is because if, for instance, your family member's admitted and now maybe they've had a severe stroke or something like this, and they can't make their own decisions, or maybe they have dementia, and trying to assess that decision-making capacity on the patient is going to be important. And they might ask, the healthcare team might ask a family member, a husband, a wife, a child, what the patient would want done in these particular situations. And I think having those discussions before the incident that brings you into the hospital can be very important. And as I said, these decisions are not written in stone. They can be reversed and changed at any time. And it should be a dynamic discussion with the family and the patient as the kind of clinical course goes on. There are some important questions that I would suggest kind of asking if you're admitted, you have advanced disease, or you or a family member is very sick and admitted to the hospital. And I think some of those questions would be like, when you meet with your healthcare team, what would CPR do? What would it get me after discharge? What are the chances that you could get out of the hospital with your cognition intact? Would you need to be on how do you feel about being on a ventilator or dialysis, or being in a nursing home afterwards? And is the condition that you have reversible? Is there a meaningful change after the hospital for you? I think these things can help provide information and form a good conversation with the healthcare team and with your family about what it is that you would want and how to best proceed in a moment of crisis before it happens. I hope this was helpful, and hope here in the next couple weeks to go into some more details and nuance around not just code status, but other life-sustaining treatments, things like dialysis, feeding tubes, and these sorts of things that can happen in the hospital. Be well.